But that's why I do like when I do get those trauma situations, the more mangled, bloody, bones sticking out, that speaks to what I love to do.
Hey, it's Michelle with the Medicine Couch. Thanks for joining me today. I just want to say thank you to all of the people who've been watching my videos and subscribing. I really do appreciate it. It means a lot to me. And if you haven't subscribed, why not? It's so simple. It doesn't cost you anything, but it really does help to support me and helps this channel to grow. So if you like what I do, hit the thumbs up and hit that subscribe button. Orthopedics is a specialty that many people are interested in, but it also is one of those specialties that has different areas that you can work in. So today I'm going to be interviewing a PA. His name is Ryan Desgrange, who not only has worked in orthopedic trauma surgery for many years, but is now an APP director over orthopedics in his hospital system. And so he is going to give us a great perspective of not only what the specialty is like, kind of, your schedule, the kind of cases you're going to see, but also about what he looks for when hiring APPs into orthopedic trauma surgery. So if this is something that interests you, then please stay tuned. And towards the end of the video, he's going to give us those pointers on what makes somebody a good candidate. So help me welcome Ryan to the program. Thanks for joining us, Ryan.
Thanks for having me.
Great. So you have worked in orthopedics your entire career, or have you done any other specialty?
Yeah, I first started off my PA career in emergency medicine and did that for about 7 years. And then somewhere at the tail end of the ER, I transitioned into orthopedic surgery.
So in orthopedics, it's kind of a wide specialty. What areas of orthopedics have you worked in? Has it always been trauma orthopedics?
No, initially I started in orthopedic trauma surgery, but with that, I also do consults for the hospital. And so I would see everything, every condition. I decided to switch over and live a normal life and have a 9-to-5 job. And so I actually did orthopedic sports medicine and total joints for about a year in a private practice clinic setting. And it really wasn't for me. I really yearned for the inpatient side, having that cross collaboration with multiple providers, and then ultimately went back to teaching institution.
So predominantly your orthopedic experience has been orthopedic trauma surgery, but you've kind of moved into another role now, more in administration, right? Can you tell us a little bit about that?
That's correct. I am currently the advanced practice provider director of our orthopedic service line. So I oversee our orthopedic PAs and NPs across the health system. Mainly my job is to not only take care of the HR items and credentialing and everything like that, but also the onboarding, orientation, really the utilization of their skill sets.
So what is your title actually called, or the type of orthopedics that you do? Is it just called Ortho Trauma?
So we call it orthopedic trauma surgery, but in the consultation setting, in the ER, we see septic arthritis and things like that. So not so much trauma could be, but, we still work through all those, ortho tumor and everything. So really I cover the whole gamut, but my division that I work in is orthopedic trauma surgery.
If you're working like any kind of orthopedic trauma or what you're describing, it's completely 100% inpatient, correct? You're not splitting, normally you wouldn't split time between inpatient and a clinic setting?
In my capacity previously, before I took on, a very large brunt of administrative work, I did have a trauma clinic, being a post-operative visit and certainly patient access into our trauma division. But then I also shared primarily the inpatient side of things and the consultations and the ER consultations.
So how did that work? Like during a week, did you have certain days that were clinic and certain days hospital? And what was kind of what were your hours and kind of your schedule?
Yeah, so I had a clinic. It was either a Monday or a Friday. And my clinic would run from about 8 until noon. And then I would take over and do administrative work at that time. The other days I would cover on the inpatient side, not only mentoring fellow PA colleagues, but primarily seeing inpatient consults, covering our ortho trauma surgery division. So we had our own patients on the inpatient side. And typically that sort of time frame would be 6 a.m. until 4 p.m. as far as coverage. And then I would hand off to our in-house resident and they would cover for the additional time.
Okay. And were you ever first assisting in the operating room?
Yeah, so I did first assist. Typically, this is during resident education at my current hospital. At my other hospital where I used to work, They heavily utilized PAs in the OR, so I'd be one-on-one with the surgeon. Where I'm at currently, typically we have a resident, so you kind of play a second assist.
Yeah, which is going to be more common when it's a teaching hospital situation, right? So when you were doing, especially the previous job where you were pretty much the first assist in the OR, what were your hours there for inpatient days?
Inpatient days, once again, whether it was OR or it was in the inpatient setting, was about 6 a.m. to 4 p.m. Just making sure that I had a solid handoff with the residents. Sometimes it may be a little bit sooner. Sometimes it's a little bit later, depending if I have a consult or inpatient floor work to clean up.
It wasn't often that surgeries were going longer and you were staying till late in the evening.
That is the one blessing about having residents, is that they're always there. You know, we have quite a few residents that bounce between the various specialties of orthopedics. So that at least wasn't a requirement for me. Although, you know, I do have some private practice colleagues that do have to stay there until the work's done as well.
Yeah. And what about call? Like, are you ever have call where you have to actually go into the hospital for the surgeries?
Thankfully, in my current job capacity where I'm at, I don't have to take any call whatsoever. So that was one of my key requirements of looking for a job. Prior to that, when I was in private practice, though, I would take office call. And within that 1 year time frame, I didn't get called in for any surgical cases.
Okay. And when you did call, was it, were you pretty much always on call, or did you rotate out weeks or weekends?
Yeah, so I would rotate with one of my other PA colleagues on who would take the office call. And it was primarily just post-operative questions, medication refills, that sort of thing.
You kind of touched on the type of cases that you would see, but why don't can you elaborate that on that a little bit more? And you know, don't need to list every single case, but just give us a good idea of all the different kinds of things that you're seeing when you work in inpatient ortho trauma.
Absolutely. So I am blessed. Two of the big teaching institutions that I was in, and the PAs were seen as the primary responders to a trauma consult. So the ER typically would see a patient and give me a call if there was an orthopedic injury or a question. I'd be the first one down there to evaluate the patient. So this would be, you know, a pedestrian versus a motor vehicle accident, which is very common in Detroit, or somebody on a bike and gets sideswiped, you know, to where there's hip dislocations and I'm having to put them back in place, or even Colles fractures that I'm setting, I'm reducing. We take care of amputations of fingers as well in the ER. So certainly if it's something that I can rongeur back or cut back some of the exposed bone, I'll do that. Sometimes I do have to escalate up to the OR setting as well. So I do a lot of hands-on sort of work there.
What are some of the other things people may not realize that an ortho trauma PA would be in on consults for?
Absolutely. So whether or not where I work, if it's in the ER setting or the inpatient setting, I get consults for things outside of trauma. So it may be chronic deformities, it may be even pediatrics, to where there's congenital hip dysplasia or tumors that are identified in the bone or concern for that. As well as, you know, probably one of the big reasons we get consulted is rule out septic arthritis of whatever painful joint, whether or not they have risk factors or not. And then another area that we do is infections of the hand and the foot and everything. One of the other areas is we also help support plenty of sporting events. So we'll see athletes that come in and, you know, certainly individuals that are at competitions where our staff physicians are at that maybe send an athlete over to get evaluated.
So back when you were working, you know, completely trauma, ortho trauma, and you're working an inpatient day, kind of does the day kind of have a typical flow to it? I mean, I know it depends on what comes in, but, you know, like, do you have typical times you're rounding, those kind of things?
Yeah, so we get there pretty early. Probably I don't need to get there right at 6 a.m., but I like to kind of tee things up, see what the residents, you know, are working on, catch up on any sort of patient issues through the nursing notes of the patients I'm responsible, see if there's any impending consults as well, and certainly make sure that individuals that are undergoing surgery that day that have come in through the trauma window, so to say, are all teed up and ready to go. So I really prep that up. After that, typically we have the handoff. So we do what we call running the board. So it's the residents, it's the trauma surgeons, it's the APPs that are there to kind of hear what's the plan for the day, how are these patients doing? And then we go and we round afterwards. typically we'll do at about 11:30 every day something called progressive round. So it's a collaborative approach where we have our social workers, our therapists, our nurses, and anybody else that's involved, and basically touch upon each patient that is on that floor to make sure everybody's on the same mindset, that if somebody's being ready to be discharged, we got all our I's dotted and T's crossed as well. And then basically I'm trying to get these patients discharged and at the mercy of, the revolving door of the ER and whatever consults come in, or if I get called from an outside facility, giving them information as far as if that patient needs to be sent down versus, hey, just throw them in a splint. So that's the typical day from the inpatient side.
Like a hospitalist has to take admissions from the ER. Do you do admissions as well, or do you just consult and say, yeah, they need to be admitted, and then the ER works with the hospitalist?
Yeah. So for us, ortho will take anything that's orthopedic. If there's, multiple, complicated comorbidities that seem like it's best met for a hospitalist to take care of them and us to focus on the ortho component, we'll go that route, really what's in the best interest of the patient. Certainly if it's a polytrauma, we work with our trauma surgery group as well, to where maybe they'll hold on to the patient, make sure that everything's okay. So you always think of, a head injury and just kind of watch them for 24 hours. So they may take them for a bit just to make sure everything's okay. And then, after surgery, we'll take them as our quote unquote primary.
So usually the PA or NP is the one that's going to be handling all discharges, correct?
Primarily, without any sort of hiccups, it's the PA or the NP that's going to be discharging the patient from the hospital.
And so that PA NP question, I know that PAs, because we have surgery training in our regular training, and NPs don't unless they do some kind of special program or go through first assist training. So in your experience, do you see more PAs in this role, or do you think it's fairly even, or are there more NPs in this role?
So in orthopedic surgery, we probably have more PAs than nurse practitioners. It's probably about 3/4 of the group are PAs and the rest are nurse practitioners. And then it, of course, varies because our hospital system is 5 big hospitals, that some of them are maybe primarily focused nurse practitioners and maybe less PAs, and then others are more PAs versus NPs. And certainly, we do get prior experience or preference to where maybe the surgeon decides that they would rather have a PA or NP as well. So whatever works for their practice.
Yeah. And you may know this because you're in the administrative role now, but for any NPs that are watching, are NPs generally required to get some kind of first assist certification, or are they trained on the job?
So for where I work, we definitely have nurse practitioners that if they're in the OR, they are gaining this first assist certification. There are cases to where some of the nurse practitioners don't, and it's kind of, they are trained up through there if they have the appropriate specialty certification through their nurse practitioner degree. But from the inpatient side, the consultation side, we don't require an RNFA or anything of that nature. I mean, that's really just kind of hands-on training.
So it sounds like when you're working inpatient and running your clinic and stuff, you are very autonomous, and pretty much the only time that you're really working side by side with the physician is when you're in the operating room. Is that correct?
Yes. We have various ways that PAs are used in orthopedic surgery. Some in the ambulatory setting, their clinic will have a shared clinic with the physician. Some will have a split or a side-by-side clinic. And then for me, when I had clinic, it was an independent clinic. Certainly knowing if things were beyond my knowledge, skill sets, education, I could tag the physician as part of our participation agreement that we have here. But otherwise, the inpatient side, I handled everything. Like I said, frontline person, made the decisions. If it was a case where I needed to board somebody for surgery, I of course would give the resident the heads up who's on in the OR that day, as well as the surgeon. But other than that, I made my decisions very much independently and autonomously.
What are some of the things about ortho trauma specifically that may have been a surprise, something that you didn't, is there anything that you didn't realize before you started working in this specialty? Yeah,
I guess I didn't realize how much infections out there. Yeah, you use the word ortho trauma surgery, and it's more so ortho surgery or general ortho. But I didn't know that there was that many infections. And certainly you look at the hand, all the dog bites and the cat bites and everything like that. It's a little bit overwhelming at times, but that's why I do like when I do get those trauma situations, the more mangled, bloody, bones sticking out, that speaks to what I love to do. I was actually a fine arts major going into my undergrad and then bowed out of it. But that's where I love ortho, because it is like an art form. You get an x-ray, you see this mangled extremity, you're like, okay, I have to set this. And really, it's like, how can I make this look beautiful on post-reduction imaging? And you throw splints and casts and making it look beautiful. So ultimately making the patient feel better than when they came in.
So in general, people who are drawn to orthopedics, what do you think that they would really love about a trauma orthopedics or orthopedic surgery in patients?
Yeah, so I think the big draw from the sort of position that I have is the case where you are seen as the expert in this area. You build that camaraderie with the ER staff. I mean, I know my ER staff, in most cases better than even my own orthopedic colleagues at times, because I'm down there, I'm collaborating with them, and I think that that's a big draw. But then ultimately, you get a big trauma case that comes in. You go into the trauma bay. There's 30 people in there because they want to see what's all going to happen, and you're on the spotlight and you're doing the reduction, and you're working with your pharmacy tech, your residents that are up at the head, maybe intubating the patient or whatever, and doing what's best for them. So I think that's the big draw, the adrenaline surge, and I think the ability to really practice at the top of your scope.
So conversely, what are some things about working inpatient ortho surgery trauma that is something that people may not think about, or that somebody should really consider as far as the downsides of the specialty go?
Well, with the teaching institution, it's everybody's busy. People are trying to get patients out of the hospital, and at times it's easy to become reliant on the fact that you do have specialists, where maybe somebody's shoulder is hurting and they didn't do anything. All of a sudden it's like, okay, well, it's an infection, or can you rule out infection? And maybe it's the case that the provider that's consulting you just needs a little education on, here's the workup, everything like that. So it's not too common, thankfully, but sometimes there's no imaging, there's no labs, there's nothing at all there. So that could be a little bit of a frustrator. I would say the other thing is patients that are transferred over from another facility, another ER, it could be the case where you may get the information, be able to speak to that provider directly, and sometimes you don't. And, you always want to do what's best for the patient. So working in a big hospital institution, sometimes when you want to get patients to the operating room, you may have to coordinate with other specialties because they have other injuries. And so trying to get medical clearance can be a frustration. Certainly the surgeons, I'm very cognizant of their time. So those increased delays keep them away from their families more. And, you feel the push, like, okay, where are they at? Where are they at? Where are they at? And you're trying to stay on top of it. On top of, at times, having a handful of consultations that you're trying to prioritize. And so sometimes the stress of that and, the next ask and everything, that gets to be a little bit daunting.
If you had to think about what personalities would do really well in an ortho trauma setting, and which personalities maybe should think about another specialty, what would you say?
You have to be able to multitask. That's vital. And thankfully during PA school, we get a lot of those skills developed. But then also I think you have to be calm in the face of, adversity and stress as well. So if you're getting stressed while the patient's getting stressed, and certainly we deal with pain quite a bit, it doesn't help with the situation. So I think he is going to be somebody who's confident and not arrogant, somebody who can multitask, somebody who can handle a stressful situation and take it with poise. Somebody that maybe isn't meant for it is somebody who cannot adapt to stress, or perhaps maybe takes things a little bit too personally, because certainly words, attitudes go flying at the times of stress as well, and letting it be able to run off the side of their shoulders, but also taking, that constructive feedback at time as well. And then I think that somebody who's not able to multitask, who just thinks singularly, moving from one task to the other, may not work great in the orthopedic trauma setting.
So as far as somebody wanting to move into like orthopedic trauma, do you feel like it's important that they have orthopedic experience?
Kind of some of the stuff that we look for when I hire individuals is what's their backstory, what's their passion. So I look at people with ER, urgent care, sometimes family practice, people just want to change and, the location and the speed, and maybe they want to be part of a big hospital system. But really, if I'm lucky to get somebody in orthopedic surgery, that's great. But most of the time it's somebody coming from the ER, the urgent care, who just basically said, hey, I love everything ortho. I want to learn more and be more in it.
What would you recommend for people? Any suggestions to help them start preparing and to be a good candidate to look good on a resume for somebody who might hire for orthopedic trauma?
Certainly. So I think really on a CV or resume, having what your relevant work history is. So, for me, I have an urgent care job in there, which, I kind of put in the lower rung of things. So they're not exactly categorized by date of hire. It's more or less what's the relevant experience. And certainly that's the importance of a good cover letter, especially when I look at new grads who are certainly interested in it, and maybe this job can be modifiable to supporting their knowledge. Is once you're at a PA school, pretty much everybody's kind of the same thing, but it's really in the content and I think the enthusiasm and the passion for orthopedic surgery in that cover letter that really sets that individual apart and may allow them to get that interview.
There's always that debate that some people say you should always work family practice, emergency medicine, something like that when you first come out, get that, base. But then I've heard other people argue, say, if you are passionate about a particular specialty, then just go into that. You're going to, touch on all the other parts of medicine as well. What are your thoughts on that?
So in my experience, it seems that most of the PAs that thrive and do well are ones who come from maybe a little bit more of a diverse background job-wise. So starting in that family practice, that urgent care, that ER setting helps develop that skill set to where they're comfortable managing multiple comorbidities, familiar with medications. Whereas then if you jump right into orthopedic surgery, you may not get that, especially when you need medical clearance and, heaven forbid, you have to risk stratify, should this patient even undergo surgery, uncontrolled diabetes, what does that mean, and everything like that. But at the same time, I think if you have this drive, if you have this passion, so, I look at athletic trainers, they have this sports focus and ortho and everything like that. I do not derail them whatsoever. And in my experience, a lot of them that have had that focus that they want to do orthopedic surgery, they stay in that. And if anything, they augment picking up moonlighting shifts in the ER or the urgent care. So I don't dissuade them either way.
So going back to that question about asking about what you would advise people to help them prepare to work in orthopedic surgery, are there any kind of CME kind of courses, any kind of national societies or anything that they should be involved with, do you think?
Yeah, so throw my little advocacy hat on. I think that any PA should be part of AAPA and their state constituent organization. I think it's important to understand the laws, the rules, the regulations that govern all of us, but also to help be a great advocate for the profession, become involved. But from a specialty organization, there's the physician assistants of orthopedic surgery, or PAOS. You have what I belong to, the Orthopedic Trauma Association, or the American Academy of Orthopedic Surgeons. So there's a lot of things in the orthopedic specialty world that PAs can belong to that I think are great. When I bring on, say, a new grad, a lot of times I'll say, all right, let's look at having you read up on the Handbook of Fractures, and it goes over everything. So it gives them a little bit of good information. It's also the case to where, I direct them towards Radiopedia. I think it's a great resource. I think back to my own PA education, I didn't really get a lot of radiographic interpretation skills. And, I think that's pretty lacking in most cases across PA programs. But I think I try and challenge them that the more normal that they see, the more that I think abnormal will stick out to them. And just even looking at an image and saying, that doesn't look right, that doesn't look anatomic, prompts the question of them diving in and trying to figure out why. And I think that's the important thing.
Yeah. When you said Radiopedia, is that like a particular book, or I don't even know?
Yeah, it's an online resource. So they actually have on their quizzes and everything. They give a patient scenario. They have some imaging, and so you try to diagnose it and what your next steps are. I think it's a fabulous website. Even Ortho Bullets is one of those big ones that all the APPs, primarily orthopedic residents, refer to as far as quick, easy, so for me, when I started my career, that's exactly what I had open. So I'd get a consultation when I was, moonlighting and cover 24, 36-hour shifts. They'd give me a call, I'd see a fracture, and I'd be like, all right, so this is a proximal humerus fracture. What classification is this? What's going to be my treatment plan? What's going to be the follow-up for the patient? That way, so when I meet them, that's their question, right? Ryan, what's the next step? Does this require surgery and everything like that? So a lot of times I would use those mobile resources to kind of really be up to speed to answer those provider-focused questions, but also patient-focused questions as well.
So if somebody is in school, they're watching this, or they're a PA student, and they are looking at rotations, what rotations other than specifically orthopedics do you think are helpful? I mean, they're all helpful, but which ones do you think are specifically helpful for orthopedic surgery?
Sure. So I think that there's great value in your family practice rotation because, you see chronic, joint pain and things like that. Certainly family practice, they do arthrocentesis, they do steroid injections. Certainly the ER, in my experience, especially if you're going to be first assisting, to kind of get those hands-on suturing skills and, take a look at the patient saying, what's the worst case scenario? Let me rule that all out and make sure that's not the case, and then kind of dive in. So really kind of having that triage level of skill set. And then certainly the urgent care, which sometimes is, either in replacement of an ER rotation, or maybe it's an augment of a family practice. But I would say that those areas outside of surgery are probably the heavily focused and most beneficial to somebody looking at orthopedic surgery as their career.
What about neurology? Does that go hand in hand, or not as much as you would think?
It does. I think that there's kind of like a gray area to where those PAs that are interested in spine, so orthopedic spine or neurosurgery, that I think that would be helpful. Certainly when you think of the dermatomes and the nerve distributions, there's obviously some crossover when we talk about compartment syndrome and what to look there. Being able to do a good neuro exam to be like, okay, well, I think maybe it's this compartment being affected because the person has foot drop or something of that nature as well.
We kind of talked about the standard cases you see and kind of what a standard schedule is like. Is there anything else that sometimes PAs or NPs in orthopedic surgery might be involved in that other people wouldn't think about?
Yeah, so certainly outside of community education on, say, joint replacement surgery and what to expect and so forth, I think one of the big things that we see is also PAs teaching other PAs and NPs, but also even residents and physicians. Myself, I'll do a lecture with our ER PAs and residents as well about common orthopedic consultations and workflow. With me and my work with our trauma service, we've had a couple publications. More specifically, we did not have balanced skeletal traction really set up or organized on what was standardized. And myself working with them, we were able to do that. And balanced skeletal traction is, you see those pictures to where they're up on a trapeze and everything like that and suspended, that we were able to do that and actually got published and created a video for the Orthopedic Trauma Association that's in their resident video library for other healthcare providers to be able to refer to and, maybe hone in their own healthcare institution.
Great stuff, Ryan. Thanks for giving us a glimpse of what it's like to work in inpatient orthopedic surgery. If you're somebody who's interested in orthopedics, but this isn't the aspect of orthopedics you want, don't worry, I will be doing interviews in the future with more people working in various aspects of orthopedics. So keep an eye out for those. If you're interested to learn more about other specialties or see what other PAs and NPs are doing, then you can watch these videos here or go look at the playlists on my main channel page. As always, thanks for joining me. Take care, stay sane, and I'll see you next time on the Medicine Couch. Bye.